if you look at where patients go after they have catheter-directed lytics, the routine catheter-directed lytics, 100% of these patients in the practice in the United States now go to an intensive care unit bed. As you well know, this is a big economical issue, especially since COVID. You know, the ICU bed situation is always tricky. It is hard to find a bed. It is expensive to put a bed in the ICU because of nursing and everything else. And when you put a patient in the ICU, you also remove that possibility, that bed, you remove it from the way of another patient who may need that ICU bed. So there's a lot of ramifications to that. Plus, it's very uncomfortable for the patients to be in an ICU bed. So forgetting about the cost and other ramifications to the society, it's very uncomfortable. If anybody has been in ICU, it's very noisy. There's a lot of intrusion. There's a lot of devices. Your family cannot stay with you. They cannot visit you. It's really hard. And although people say, well, we're just going to watch him 6 hours in the ICU, it's never been my experience that a patient stays 6 hours in the ICU. It's always that they have to wait after that for the bed on the floor. They stay overnight. Nobody's going to transfer them at 2 a.m. So it ends up being a whole day in the ICU. So that's not just 6 hours. So even if you want to say, I want to put patient for 6 hours in the ICU, it's a whole day of ICU stay. So all that makes a big difference for the patient, makes a big difference for the hospital from a cost standpoint, make a difference for society from a societal standpoint, and from a bed utilization standpoint. As far as comfort, um, I haven't had the procedure myself, but I'm assuming going in with a 6 or 7 or 8 French catheter would be easier and less discomfort and less hematoma than going with a 24 or a 26 French catheter. So we really have not seen necessarily that using lytics is going to increase the complication rate when it comes to access. So that I'm not worried about. So if I'm putting a smaller catheter in a patient and the patient is able to not go to the ICU, um, and if I feel I'm getting rid of the distal obstruction, I think I've got a good procedure there.